turning a Minnesota group practice into an IOP or PHP is a real operating change, not a marketing label. In Minnesota, the threshold question is whether your planned service stays ordinary outpatient practice or becomes a licensed substance use disorder treatment program under DHS Chapter 245G. Treat IOP or PHP as a label, and licensing, payer, and workflow assumptions become expensive launch blockers. Treat it as a real conversion, and you scope the right plan first. This guide walks the questions to resolve before you market the program: licensing, clinical leadership, your location, and Minnesota payer readiness. So, what does this conversion actually involve? A therapy group adding structured SUD IOP or PHP services has to think beyond clinician availability. It has to operate as a program. The readiness questions move into DHS Chapter 245G analysis, ASAM-aligned documentation, MHCP and payer enrollment, staff credentialing, and utilization review. This is a decision guide, not legal advice or a self-serve launch manual. Use it to identify the questions to resolve before you change your public service model. Here is what makes this risky. A group practice should not assume its ordinary outpatient enrollment and claims setup will support structured SUD IOP or PHP services. Clinical leadership has to own level of care fit and documentation so the program can prove medical necessity once census, authorizations, and denials become daily operating issues. Licensing, payer, site, and workflow questions should be resolved before you commit to a launch date, a marketing campaign, a lease change, or revenue assumptions. Your software belongs in the same analysis. Behave Health's EHR, CRM, and RCM are designed to support admissions, group encounters, authorization tracking, and Medicaid and commercial claims. Before you market the program, there are 4 questions to resolve. Let us walk through each one: licensing, clinical leadership, your location, and Minnesota payer readiness. First, the licensing path. The official Minnesota source path starts with DHS substance use disorder treatment licensing, and Minnesota Statutes Chapter 245G is the current statutory framework to review. Keep the source paths separate. Detox and withdrawal management framing belongs in a different analysis unless those services are actually part of your proposed program. Which agency has authority and what service definition applies should be confirmed with the state agency, qualified counsel, and your payers before marketing. Second, staffing and clinical leadership. Structured IOP or PHP care adds a different layer of program leadership on top of your existing clinicians and intake habits. Clinical leadership has to own level of care fit, ASAM-aligned assessment, treatment plan updates, group programming, utilization review, and discharge planning. Do not build the staffing model from a generic matrix. The right exercise is a tailored review of your service model, 245G path, credentials, and documentation workflow. Third, whether your current location can support the program. Many practices want to use the current office because it is already leased and familiar. That may work, but it should not be assumed. Group rooms, privacy, check-in flow, accessibility, parking, and emergency procedures matter more when clients attend multiple times per week. Confirm whether lease, zoning, fire safety, and payer readiness questions are aligned with the proposed use before you commit the site. Fourth, Minnesota Medicaid and commercial payer readiness. Minnesota payer readiness should run alongside the licensing analysis, not after it. Public payer participation is often part of the conversion question. Review MHCP participation, Minnesota Medicaid enrollment, managed care requirements, commercial contracts, service authorization, and denial management workflows. Verify provider enrollment, medical necessity criteria, and level of care billing with Medicaid, commercial payers, counsel, and Behave Consulting before relying on the revenue model. Your software belongs in the same readiness analysis. A converted Minnesota program should review whether its platform can run as a program. Behave Health's EHR, CRM, and RCM are designed to support admissions, group encounters, and treatment plans from one workflow. Authorization tracking is designed to keep level of care reviews and concurrent reviews visible as census grows. It is designed to support both Medicaid and commercial claims, with denial follow-up and reporting in one system. It is built for the outpatient billing codes Minnesota programs work with: H0015, H2036, S0201, and S9480. Keep this work at the readiness level until the model is professionally reviewed. Verify the current Minnesota path with DHS and Chapter 245G sources. Confirm MHCP resources, managed care plans, and commercial payers. Bring in qualified counsel and your implementation team before you announce. Payer scripts, fee schedules, and launch calendars belong in a private operating plan. Stop letting licensing and payer assumptions become expensive launch blockers. Pressure test the model before you commit capital. Behave Consulting helps you pressure test the conversion, and the platform supports it once the structure is ready. Book a demo at behavehealth.com.